Well, good afternoon, everyone. I really enjoyed coming to last year's course. And so when Pat asked me to come back this year to course 1, I immediately said yes. And so it's great to be here. And what I'm going to do in the next half hour or so is to go over with you diagnostics needs for global health. And because I know that you'll be getting a lot of other lectures about STDs, HIV, etc., I would focus on the more neglected tropical diseases for diagnostic needs. And then I'll go into why these needs are unmet by looking at the landscape of what diagnostics are like in developing countries. And then I'll end up on a hopefully more optimistic note with opportunities and the way forward. Now, I said to Pat, I warned Pat that I'm going to be asking some questions of you instead of giving a straight lecture. So this is a list of initiatives that are supposed to improve global health. And so I'm going to ask if you know for each one of those what diseases would apply. For vaccination, I think that's obvious. A lot of people do know for what diseases vaccination has made a big difference in global health. Anyone? Measles, yeah. So we just gave some examples here. Vector control for diseases that are transmitted by insects, mainly mosquitoes. Malaria, yes, yeah. Dengue. Dengue is one of the, I think, fastest growing diseases in the world at the moment. And then African sleeping sickness is a very neglected disease. Control of intermediate hosts, perhaps not so common in other than parts of Africa and Asia. It's schistosomiasis and then guinea worm. What about improved water supply and sanitation? What diseases would those? Yeah, that's right. Yeah. Typhoid, yeah. And then community-based mass treatment. Now, there are a number of diseases for which that's a main control strategy. Yes, that's right. And so for onchocerciasis, that's the cause. That's river blindness, and lymphatic filariasis, the sort of elephantiasis, and for trachoma and schistosomiasis. Those are diseases for which diagnostics are not part of the control strategy. So the control strategy is mass treatment of communities where the disease is endemic. But what has happened now is that after rounds and rounds of mass treatment, without a diagnostic, how do you know where there are still pockets of infection? How do you know when to switch from mass treatment strategy to targeted treatment of at-risk individuals? So, and then when do you progress towards elimination? And so those are the kind of tools that we should be looking at for these diseases. And then for screening or case finding. So this is typically for diseases that are asymptomatic, especially at first, in the early stages of disease. Yeah, and any others? Chlamydia. Yeah, chlamydia. So most STDs, TB, HIV, syphilis. So these are diseases that you want to screen for very early because the consequences of not treating them are very serious. And then there is also intermittent preventive treatment, which is used for malaria in pregnancy. And so now if you look at all these initiatives that would improve global health, diagnostic figures in a lot of these diseases, but for different reasons, not always for case management. And so for each one of those, you will need a different set of product profiles or target product profiles. Now for malaria, the disease burden is high and the mortality is mainly in children. And so what is currently used for diagnosis of malaria in most countries? Microscopy, yeah. And microscopy is over 100 years old. And so we should really be looking for more effective diagnostics. So there are, at the moment, about 123 or 24 companies that make malaria diagnostics. Sorry, I should say 123 or 24 brands of malaria rapid tests made by about 60 companies around the world. And so at WHO, we set up a scheme to evaluate these tests to know what their performance is like. And there's a big variety of performance profiles, and some are very sensitive and some are not. But a lot of them are actually very, I guess, thermolabile. And so if you transport them in a van, and the van sits in the hot sun for about 2 hours, and the temperature gets up beyond 40 degrees, these tests don't last very long. And so even though the industry standard is that the results of these rapid tests are guaranteed, for I guess at up to 30 degrees only, you could use them in temperatures that are above 30 degrees, but it would have a shorter lifespan. So if it says that the expiry is for next year, but if you're going to use it in a 35 to 40 degree temperature environment, then you would expect the expiry to be a lot sooner. And so this has now become a real concern in many settings where when do we know that these rapid tests are no good? So I think one of the things that I will talk about later is we need to have quality control materials, because these rapid tests don't come with any quality controls. And so you wouldn't know if they've expired and they're no longer working. Now, another disease that I said is quite neglected is sleeping sickness. And there are not very many new cases a year, but the fatality rate is about 70% if the cases aren't treated. And unfortunately, this disease is in a lot of war-torn areas. And so getting to the patients is a problem. So you want to be able to, once you reach patients, you want to be able to diagnose them right away and give them the appropriate treatment right away. Now, the two treatments that are listed here are for different stages. So when the infection's in the blood, then you would treat with pentamidine. But when it's advanced to the brain, then you need to have another type of treatment. And both of them are toxic. And so you cannot just do mass treatment, or you cannot do presumptive treatment. You really want to be able to diagnose them. But the staging requires a spinal tap. And so these are normally done in resource poor settings, just under a tree. And so we really need for this disease to have some easier way of staging the disease to give the appropriate treatment. So right now, microscopy is one of the standard ways to diagnose the disease. There is an IgM test that is on the card. It's an indirect agglutination test, but it doesn't tell you what stage the patient is at. And so for the staging, what we typically do is either look for parasite in the CSF or look for white cells. So when you have white cell counts that are less than 5 in 30 high power fields, then you would say that this is stage 1. And if it's over 20, then it's stage 2. But then there's a gray area in between, and what do you do about that? And nobody has the answer at the moment. And so this is another big diagnostic need. Now, visceral leishmaniasis is very common in parts of Africa. In the Indian subcontinent, it's also a very important pathogen. And at the World Health Assembly in 2005, the governments of India, Bangladesh, and Nepal had committed to eliminating VL from the Indian subcontinent by the year 2015. And for that elimination to happen, they really need to be able to do a lot more case finding than they are at the moment. And for this, we need rapid tests. And so there are some rapid tests that we evaluated while I was at WHO that are good, but the minute that the Indian government announced that these will be the tests to be used for the elimination, counterfeit tests with the same name or the looking alike, the products that we approved, appeared on the market. And so these counterfeit tests normally would not detect anything. Some of them are just blank strips in effect. And so the elimination would not be achieved if the government doesn't get rid of these counterfeit tests from the market, because in most countries, about 50 to 70% of the patients go to private providers who have no means of knowing whether these tests are good or not. And so this is another area that, again, with all the rapid tests, the quality of the test itself and how do you verify the test is a concern. So this is one of the tests that we found to be good. It's very simple. It's a lateral flow test, and very simple to do in a few steps. There is also a latex agglutination test to detect antigen in the urine. Now, you would think that that would be a very easy test, but the sensitivity is quite poor, and you have to boil the urine for 10 minutes. And so that's not a very field-friendly test. Imagine pots of urine being boiled all around you. It's difficult. Now, okay, another tropical disease that I mentioned, schistosomiasis. In China, apparently eggs of Schistosoma japonicum have been found in the intestine of mummies that were in China from over 2,000 years ago. And so it's a very old disease, and in the old days, you could see in villages where it's endemic, lots of people with the very extended bellies from their ascites caused by the parasite. And the intermediate host is the snail. And China actually eliminated schisto about 50 years ago. Last year was the anniversary, the 50th anniversary of the elimination. It was Chairman Mao's idea to ask every school child going to school to pick up snails with their chopsticks so that they don't touch the snails, and put them into a can, and then when they reach the school, they hand the cans over to the teacher. So that was very effective. To remove the intermediate host is really great. But of course, it doesn't actually, it reduced the infection to a very low level, and so you no longer see people with the extended, distended bellies. But with the Three Gorges Dam project, over 1 million acres of land were, resubmerged in water. And so now there's a re-emergence of schisto. And the government is very keen to measure the baseline before they start any aggressive vector control methods as well as treatment methods. So in China, we helped the Chinese government with finding, evaluating different tests available for schisto and finding which one is the best to use to have a national survey of the prevalence of disease, and also identify where the infection is along the Yangtze River. And so, so that's one of the projects that we've been carrying on that would actually lead us to diagnostics that are for surveillance as opposed to patient management. Now for dengue, the dengue belt, as we know it, is indicated on those lines. And it's been expanding because of global warming. And so there are now outbreaks that's been identified in places where previously there had been no outbreaks. And I know that in the United States, southern United States, have dengue. And the last big outbreak was actually in Africa, in Senegal and Cape Verde. And we had not expected that there will be outbreaks there. And so we're trying to identify these outbreaks with accurate diagnostics. So there are quite a number of different diagnostics for dengue, but they are not as good as they could be. And so this is one area where there's a lot of demand. Now, I think you just had lectures on sexually transmitted infections from King Holmes, and so for sexually transmitted diseases, we've identified that access to diagnostics is very limited in areas where there's a lot of disease burden. And so, do you remember from the lecture, from King's lecture, what are the priorities for diagnostics for STDs? Any guesses? Or did King say no? Assured, yes. Well, that's that could apply to a lot of them. Yeah, but which STDs would be important to screen for?
I would guess HIV.
Yeah, HIV, that's for sure. But okay, so chlamydia, gonorrhea, because those have even though they would be symptomatic, but they have very serious consequences, such as leading to PID, ectopic pregnancies, and infertility, tubal infertility. And so it is important to screen for these diseases in both high-risk populations and also to support syndromic management, because syndromic management for vaginal discharge is not very accurate for chlamydia and gonorrhea. And because there are a lot of vaginal infections that would be the cause of vaginal discharge. And so you ended up, if you use the WHO syndromic management algorithms, you ended up over-treating for chlamydia and gonorrhea as much as 90% in a lot of settings. And so we recommend adding the rapid diagnosis to syndromic management for vaginal discharge. And the kind of specimens that we would like is to have vaginal swabs and for women and urine for men. Urine specimens don't work very well for women, and so we recommend vaginal swabs. For syphilis, the consequence of syphilis, especially for pregnant women, is so serious that I think that there's in almost every country in the world there's a policy for screening for syphilis in pregnancy, and because a woman who's infected with syphilis during pregnancy or before she was pregnant has a third possibility of the fetus dying in utero, so it would be a stillbirth or she would have a miscarriage, and a third of the time the fetus, the baby would be born live, but with chronic symptoms of congenital syphilis, which could be very serious and requires a lot of care. And then a third of the time, the pregnancy could come out normal, depending on when the woman was infected, and the longer she's been infected before she became pregnant, the less likely the baby would actually get infected. I think the worst is when she acquires a primary infection during her early stages of pregnancy. And for that, we would like to have, we have now whole rapid tests that could use whole blood, but ideally we'd like to have something like a saliva test, which is available for HIV, but not not for syphilis at the moment. So those are the some of the unmet needs that I just talked about. Now, why are these needs unmet? I think that we always say that diagnostics are undervalued. In the US, while diagnostics comprise less than 5% of hospital costs and about 1.6% of all Medicare costs, their findings actually influence as much as 60 to 70% of healthcare spending. So that's in the US, and we thought, well, maybe in the US hospital costs are high. But we find that actually in a WHO task force finding on health economics and cost analysis in a district health center in Malawi, that diagnostics, again, only is 6% of the budget. And so for something that influences a lot of the decision-making in patient care, this is a very, very small investment. And so we're always saying, why doesn't diagnostics attract more money in terms of investments? And so Jeremy Schiffman at the Maxwell School in New York has this theory is that it's all to do with politics. It's not really about how many deaths it costs, because we know that for HIV, there's a lot of political commitment for HIV, and even though the deaths, there are not as many babies who die from HIV as die from syphilis, and yet a lot more money is paid towards preemptive CT programs to prevent HIV in babies than for syphilis. And the same with SARS, and the most recent example is flu. A lot of money had been put on to flu and flu prevention. Now, what is the diagnostic landscape like in the developing world? First of all, as I said just now, for diseases for which we really badly need a diagnostic, there's very little industry interest in developing quality diagnostics for these diseases due to a perceived lack of return for investment, because they happen in more resource-limited settings, and they figured that nobody could afford to buy the test or expensive tests, so they can't make any money off it, so they are not willing to spend the money. And also, it's also the fault of governments for not putting investments into better diagnostics for patient care. The second thing that is very important in terms of priorities for better diagnostics in the developing world is that there's a lack of access. A lot of patients in the developing world cannot access diagnostics because there are so few labs in developing countries. And I'll show some details of that later. So they're not accessible physically, these diagnostics, nor are they accessible financially. So quite often, for chlamydia, lots of very, very good tests exist. But at $15, $20 a test, it's just not accessible to many patients in many countries. And then in most countries in the developing world, there's a lack of regulatory control. So I think you're very fortunate here to have the FDA regulating the performance and characteristics of diagnostics. In many countries, diagnostics could be they could register and be sold without having the government know whether they work or not. So tests are being sold and used without any evidence that they work. And the downside of that is that it discourages companies with good tests to compete in that kind of market when it's flooded with bad tests. And then lastly, there's a lack of quality standards on how to evaluate diagnostics. So it leads to a lot of misleading information on the product inserts, and I'll show some of those examples later. Now, first of all, inequity of access. So the 2004 Health Development Report put out by the World Bank cited the lack of access and unaffordability as two major reasons why health services fail. And they listed in a table, and this is only excerpt, I selected a few countries from that table, to show the distance that the patient has to travel to get to a clinic or medical facility. And there's no guarantee when you get to that facility whether there's a diagnostic there or not. But at least you could now see the kind of distance that the poorest fifth of the population have to travel in order to get to medical care. And can you imagine if you're sick or you're pregnant that you have to walk those distances, or you have to carry your sick child on your shoulder to go to those places? Now, the implication of that, if we look at a model looking at pregnant women with syphilis, if we start with 100 pregnant women who have syphilis, and according to UNICEF, in recent years, the access to antenatal care has really improved a lot, from between 45 to 50% to about 75%. So let's say 75% of pregnant women can access antenatal care. But of those antenatal clinics, only, and only 50% of those women would actually go early enough in pregnancy for the screening to really be effective. So ideally, for syphilis screening, you want to be able to detect the infection before the end of the second trimester for the shot of penicillin to be effective in preventing infection to the fetus. And so only about 50% of those 100 women would actually go to the antenatal clinic early enough in pregnancy to access the screening. But not every antenatal clinic has screening. So now we're down to 25 out of the 100 women would get actually tested at a place where they offer syphilis screening. And then quite often, I don't know if you're familiar, but in a lot of countries they use the RPR, which is a fairly rapid test. You could get the test done in 8 minutes. But because it's on the card, so you typically, there's 10 spots on the card, so you don't use just the one spot for each patient. You wait until there are at least 8 or 9 patients to batch the testing. And so then it always requires the patients to come back, either the next week or the next day for their results. And quite a lot of them don't come back. So can you imagine if you walk 12 hours to reach the clinic, and then they draw your blood and they say, come back next week? That's pretty hard, especially if you're pregnant. And so a lot of them don't come back. And then when they come back, sometimes the results are lost, because the results were, the blood was sent away to another clinic to get tested, or that the results themselves are lost in terms of medical records being lost. And so, or when they come back, there's no penicillin. The clinic has run out of penicillin, so they cannot be treated. So in the end, because of all these reasons, only maybe between 10 to 15% of the women get screened and treated for syphilis in pregnancy. And so this is quite a normal scenario. And so what we hope is that with rapid tests that are effective, they're accurate, and they can give you a result right away, that you could actually increase the screening rate to at least 52% of the women that access the screening early in pregnancy. So that's the power of having a good point-of-care test. Now, I've mentioned that the lack of regulatory oversight for diagnostics is a big problem. So when I was at the WHO, we conducted a survey in 2002. We wrote to every member of the UN and asked them if they regulate in vitro diagnostics. this is outside of blood banking. For blood banking, there's a lot of countries have very strict regulations. But these are in vitro devices for infectious diseases that are not used in blood banking. And just over half of them say they don't. Now, of those they did, we asked them what they do to have some oversight on these tests. A lot of them say they require clinical trials. And then we ask them, you know, what do they do? Is it like the FDA where you go through clinical trial design with them? No, they just accept the data as is. And so, so we find that there are these tests. Now, this is a gonorrhea test that we found at a sex shop in China. Don't ask me what I was doing there. We were doing some, we were actually looking for rapid tests that are sold in private vendors. And so if you could read Chinese, you could see that on here there's a set of, I guess, not instructions. They say that the performance is very simple to use. The reaction is extremely rapid. And you can diagnose gonorrhea in 10 seconds. Very good. Doesn't work at all. We put 1 million gonorrhea organisms in there, and that didn't turn color at all. So how good are they? Not worth the money that you want to put in. And then for dengue, there's been a lot of governments that want to have information on rapid tests for dengue, because every time they have an outbreak, they ask, you know, what are the best rapid tests that we could use for dengue? And so on your left-hand side is a panel of accuracy that was claimed in the product insert that comes with each test. And then the Western Pacific Office of the WHO commissioned a study to look at, to evaluate these tests using over 400 serum samples. And these are the results that they found on your right-hand side. And so the sensitivity doesn't resemble what's claimed in most cases, unfortunately. Specificity seems to be fine, but the sensitivity is quite poor. Yeah. So this is published, but these tests continue to be sold. And we also evaluated 19 TB serology tests. Now, in the US, you wouldn't use serology tests. These are lateral flow tests that detect antibodies to TB. So normally you would try to, if you suspect a TB case, you wouldn't use antibodies. But maybe it has a role in ruling out exposure to TB. But we evaluated 19 of these rapid tests because they're used by physicians around the world. And unfortunately, they are not very sensitive nor very specific. So the worst one of the slot is a test that has a sensitivity of 0.97%. And so can you imagine 100 TB patients walk into a clinic, and if they're using that test, then only one of them would walk out of the clinic with treatment for TB. 99 of them would walk out thinking they're TB-free, and they will continue to transmit it to their families, their co-workers, their neighbors, etc. So really, the evaluation, a really vigorous evaluation of these tests are really required. So with all this that we found out, so what do we want? So the ideal test that we want for global health is one thing, a test that is accessible for most of the population. And it has to be affordable, and it has to be accurate. So rather than saying these properties all the time, I coined this acronym, ASSURE, to say that we want A for affordable, sensitive, specific, U for user friendliness. So that's a test that could be done in a few steps. and give you a rapid result, perhaps under 30 minutes. And it has to be robust. It could be stored at room temperature so that it doesn't need refrigeration. And that as far as possible, equipment free, or use small equipment that doesn't require electricity, and deliverable to those who need them. And so now, if you think about how to configure the target product profile of your test, think about the accessibility in terms of different levels of the healthcare system. And so this is a slide that I got from FIND, the Foundation for Innovative New Diagnostics in Switzerland. And this is for TB. So they figure that if you have a test that can be only done at reference laboratories because it's highly technical, requires a lot of technical expertise, it's expensive, then you're only really reaching 5% of the population. But if you have down to the lower level, at a lower level, maybe you could do some drug susceptibility testing, maybe you could do culture, then you're reaching another 10%. And beyond that, so the equivalent to most African healthcare structures would be that the bottom layer, the peripheral health clinic, would be like the dispensaries, where it's a one room only. There won't be any electricity most of the time, and so you would have to have a point of care that doesn't rely on electricity at all. And so that's about 60% of the population would actually go to seek care at those clinics. And that if you have a slightly more sophisticated test that could plug into electricity, small machine, etc., but it's better than microscopy, then together you could reach about 85% of the people. So think about, when you think about your how to configure your test, think about how many people what percentage of the population you could reach with this. Now, so enough of gloomy statistics, etc. So on a more optimistic note, there are now, in recent years, more funders. The Bill and Melinda Gates Foundation, the NIH, the Wellcome Trust, USAID, the European Commission have now all invested money in better diagnostics. And the Department for International Development in a lot of countries, like the UK, Sweden, etc., they've also invested they have calls for proposals for diagnostics. There are more players now, more product development partnerships. Just in the Seattle area, there's PATH, there's the Infectious Disease Research Institute, and a whole number of smaller companies, as well as the traditional big companies that work on diagnostics. And also in terms of technical advances, the human genome has been sequenced, a lot of the pathogen genomes have been sequenced. So there are opportunity to look for new markers. And so genomics, proteomics, etc., all the omics that you could think of, now we could bring them to bear on new diagnostics. And then thanks to investment of different governments in rapid detection technology to fight terrorism, there's a lot of nifty new technologies to detect markers. And so those could be actually applied to rapid diagnostics. And so when I was at WHO, one of the things that we really want to promote is to build the capacity of developing country scientists to work on diagnostics and drug development for diseases that are of public health importance in their own country. instead of always relying on adapting technology from the West, etc. And so we started a network for innovation, which we started in Africa. We've now extended it to Asia, and we'll be extending to the Americas pretty soon. And so I'll talk a little bit more about that. We want to really promote innovation to address emerging needs. And also, I think we need to maximize resources by thinking of diagnostic packages, not one diagnostics for every single disease. Because when patients present, doctors are thinking about syndromes, a set of signs and symptoms, and then trying to think what those diseases, what could be the cause of those syndromes. So think about multiplex packages, and I'll talk a little bit more about that as well. And we really want to be able to link product development to disease control needs. Typically, in many countries, the Department of Health doesn't talk to universities, doesn't talk to companies. They are in different parts of the government. And in many universities, the research is investigator-driven. But more and more now, governments are able to actually link up with the Department of Health and put out specific calls for, for tests, for dengue or whatever, to actually try to bring these different players together. And then one last thing I would plead for is to have some way to ensure the quality of not only the diagnostic tests, but the testing. And so if we think about innovation, I like you to think about that. In terms of TB, you know that TB has a lot of new cases. Last year, I think there was over 9 million cases, and 2 million people died approximately a year. Now, if we think about drug development alone, this is a slide that we put together when I was at WHO to think about the development. It takes approximately 100 projects involving over 100,000 new potential targets to get to the end where you actually have one or just more than one product brought to market. And typically it takes about 800 million to about $2 billion and about 10 to 12 years to bring a new drug to market. That's been the record, and that's been the way it worked. And so there's a big innovation gap because not many people like to work in the sort of the upstream side because it's high risk and it's very expensive. And so we call that part the valley of death. And for diagnostics, we don't even know how deep the valley of death is. At least for drugs, they have that. Now, if you think back to the TB problem, and thinking about 2 million people die a year, how many people would die before we get a new drug, a TB drug to market? That's a lot of deaths, 20 million deaths, before we get a new drug to market. And the same with diagnostics. Nowadays, with the speed of transmission of any new disease or any outbreak, we cannot afford to wait 2 to 5 years to develop a new diagnostic, right? And so we really need to find new ways to work quicker and smarter and collaborate. And so this is what the innovation networks are all about. And I think that if you would like to know more about these innovation networks, you could go to the WHO TDR website and you will find the information there. And so we typically wanted to foster a global research effort in which the disease endemic countries play a key role. And so we start with building capacity, we link up everybody working on the same things. We actually talk about how to set up quality assurance programs and also bridge research to policy. And we actually map out the capacity of different places in Africa to do drug discovery, development, etc. And there's actually a lot, but they actually typically don't work together they have collaborators in the West rather than with each other. So what we want to do is to get them working together within the continent for diseases that are important in their own area. And this is to promote this network. We've now got the support of major funders, and so it's going forward. And as I said, in Africa, in Asia, we just started a network, first in China and then in India. And later on in the year, we'll link up the other countries as well. Okay, so that's innovation. But while you're thinking about what products, I really like to bring your attention to multiplex diagnostics, because in 2004, when I found out from our sites in Haiti and in Tanzania that in a lot of the pre-empty CT sites, the babies are, the moms are screened for HIV, and they were given treatment, so babies are born free of HIV, and yet they die of syphilis. And for less than $1, you could have saved that baby if the syphilis screening was actually carried out together with the pre-empty CT package. And so we really, so I wrote this article in The Lancet to comment on that. And I think that I've never had so much reaction to this. Everybody says it makes sense. But how do we get funders to actually allow that? So at that time, the Global Fund does not allow their funds to be used for diagnostics other than HIV, malaria, and TB. But since that article and some lobbying years later, the Global Fund now allows syphilis tests to be purchased using Global Fund money in pre-empty CT programs. So think about tweening tests together where it makes sense, right? Because a woman who's at risk for HIV is also at risk for syphilis. And of course, the famous fever stick that we're all looking for. And then a multiplex for tests for pneumonia, one of the biggest causes of childhood mortality. Now, as I said before, many ministries of health actually don't talk to product developers. They don't talk the same language. I've actually convened meetings where we bring them together and they stare at each other across the room and don't know how to start to talk, because on the one hand, there's all these technical people, and then on the other hand, the other people who all know about diseases. And so I think courses like this actually are great because you do bring them together. And so maybe then we wouldn't need an elbow joint, like it says in the cartoon. Now, so this is a typical pathway, and I'm sure many of you have different versions of the same pathway. But I want to say at this point that it is a long road to start with some targets, some novel targets, to be able to validate them and then put them into a product, and then validate the product, and then actually get regulatory approval for them, and then get them out to be used by healthcare workers. It is a long path, and we have to try and accelerate, do whatever we can to accelerate that. And at WHO, what we did was we have some funds for Bright Ideas programs for the upstream. And then when people have really good sort of prototypes or existing diagnostic tests, we evaluate them at our field lab and field sites for free. And then any tests that are actually that show acceptable performance, we enter them into the WHO bulk procurement scheme at negotiated pricing. So it's a win-win situation for manufacturers as well as for countries, because the manufacturers save money by not having to go and do marketing and distribution in 193 countries. Because the countries can actually order directly from the WHO bulk procurement scheme. And then countries actually benefit because typically the manufacturers bid into the bulk procurement scheme at a negotiated price. and not at the full retail price. And so it is a very, very good situation. And then finally, I want to say that after years of sort of speaking about quality of diagnostics and the quality of testing, finally last year the Global Fund started to think about a quality policy for diagnostics. So I think from next year onwards, there will be this quality policy would be implemented, and countries will likely be asked to produce some evidence that the tests they procure actually work in terms of either evaluation data they produce themselves or somebody else's evaluation data, and that they need to put into place a quality assurance system for the testing that's done. There was a paper published about rapid HIV testing in 11 countries in Africa, and the survey found that only 2 of the 11 countries have a quality assurance policy for a system for HIV, rapid HIV testing, which is, a little bit scary. So finally, this is my final slide to say that it's not that simple, even though we're aiming at a very, very simple test. It's not simple to make, and I don't think I need to convince you how complex it is to actually try to make diagnostics simple. And on your left-hand side is a slide that was given to me by Ray Waters. He's a vet, and he's trying to diagnose TB in an elephant. And whenever I complain about how difficult it is to diagnose diseases in humans, he said, just look at that slide. It's a point-of-care diagnostic. Yes, an X-ray machine, yeah. But it takes several people and hours to position it correctly and try to hold the elephant still enough to take the picture. So thank you very much.